Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Center for Substance Use Training and Telementoring, CSTAT at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on the three dots or more menu at the bottom right corner of your Zoom screen to find this. If you're having trouble accessing this, please chat Echo IT. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Beeville, Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your phone number and name to beeville@ithaca.edu. Please know that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any info you put into the chat will not be shared on those recordings. We encourage everyone to join by video for the discussion portion of the session in the latter half. That said, regardless of how you've shown up today, we're just happy you're here. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate that you have a comment to share. There are a lot of us in the space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no product health information is allowed in either the chat or the discussions. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It helps us give feedback on how to refine and shape these sessions to address your priorities and allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. For this session, we're also offering TCOL credits. And all participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Melanie Lowenkamp on the principles of risk, need, and responsivity. Following that, we'll hear a case presented by Joan de la Garza. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage each of you to share that during a discussion so that we can learn from each other in this space. And with that, we will do some introductions. Dr. Miramontes.
Hi, I'm Dr. Dave Miramontes from UTL San Antonio. I'm the medical director for San Antonio Fire Department. And we have a group of dedicated paramedics that start buprenorphine and engage with clients with any form of substance abuse and navigate them into care into the Bexar County system.
Thank you so much for joining us today. Cynthia.
Good morning. My name is Cynthia Mendiola, and I'm a retired federal probationer. My specialty is disorders and probation officers in corrections. Love the work. Welcome.
Thank you so much for joining us today. Melinda.
Good morning. I'm Melinda Holliday. I'm with Solution Point Plus. I'm a clinical social worker and training facilitator with them. Solution Point Plus is an organization that focuses on first responder wellness, providing CIT trainings, crisis de-escalation trainings, and officer wellness. Happy to be here.
Thank you so much for joining us today. Melanie.
Hello, I'm Melanie Lowenkamp. I work for Correctional Solutions. We are a company that works with a variety of correctional agencies from pretrial all the way through post-conviction, juvenile and adult training, primarily staff in using evidence-based practices to provide services to justice-involved individuals.
Thank you so much for joining us today. John de la Garza.
Yeah, good morning, everybody. My name is John De La Garza. I work for the San Antonio Fire Department. I work very closely with Dr. Miramontes, and I am the manager for the overdose prevention program here in San Antonio, where we operate as a mobile MAT team, referring patients with SUDs into clinics and organizations that they can provide peer support.
Thank you so much for joining us today. Andrea Hepler.
Hello, everyone. My name is Andrea Helbler. I am one of the program coordinators at CSTAT. Welcome, everybody.
Thank you so much. And Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAT program coordinator. Thank you for joining us today.
Thank you. And with that, we will get on to our didactics. Melanie, you can take it away whenever you're ready.
Okay, thank you. Yeah. All right, hopefully everyone can see the presentation on your screen. I have been invited to speak this morning on one of the core areas of research in corrections. I'm going to be talking specifically about the principles of risk need responsivity. Apologize just one day. Keep my chat up, make sure there aren't any messages. All right, so this morning, again, I'm gonna give you an overview, and this is just gonna be a very simple, quick overview, again, of these core principles, the risk principle, the need principle, and responsivity principle. Specifically, we're gonna dig into one area, the need principle, and talk a little bit about what's known in our field as the criminogenic needs. I'm gonna review the top criminogenic needs with you. And as I do that, we're gonna apply those principles of risk need responsivity to see what it looks like in terms of supervising a justice involved person. And specifically, the interest here today is someone who's using substances.
Melanie, sorry
yes.
to interrupt. Could you use the presenter mode, please?
Yes. Oh, am I? Thank you. Thanks for letting me know.
That's perfect. Yeah,
okay.
Thank you.
So what I'm going to be talking about, again, risk need responsivity, this comes from a body of research that's become known as the what works literature. So just a quick history lesson, evolution of the research. All through the course of the 20th century, there's been a back and forth between proponents of punishment and proponents of rehabilitation. Prior to the 1970s, the format or the preferred method of offender rehabilitation was in fact a rehabilitative approach, providing human service interventions, trying to correct behavior, and so on and so forth from that rehabilitative lens. However, some of you might remember the 1970s, there was quite a backlash. At that time, there were rising crime rates, prisons were becoming overcrowded, and so there was a push from the general population and politics as well to take a look to figure out what exactly is working. So there was this pushback that rehabilitative approaches don't work. At the same time, this was exacerbated by the work of a researcher, you can see on your screen there, Martinson. In 1974, Dr. Martinson published a review of 231 different studies looking at rehabilitation in the offending population. And his research came to the conclusion that rehabilitation has no appreciable effect on recidivism. In other words, he concluded that nothing seems to work. So this body of research became known as the nothing works. As you see on your slide there, this prompted researchers to push back, and there was a call for all sorts of papers and research to identify, well, what exactly does work from the rehabilitation camp. About around the same time, Palmer in 1975 reviewed his article and found that there were some flaws in his analyses and his methodology, and concluded that, in fact, close to half of those programs that were examined in the research did show some type of effect. Again, this led to a larger body or a larger call for research, and the result of this became known as, again, the what works. So what exactly works when dealing with justice-involved individuals or dealing with those that are in the justice system? This became the basis. So all of this research, all of this work that was done up to this point became the basis of, again, what I'm going to talk to you about briefly, the principles of effective intervention. The graph you're looking at, this was produced by the National Institute of Corrections. This is an overview, kind of a visual of what the principles of effective intervention is comprised of. So the principles of effective intervention, this just describes this collective framework of guiding principles and skills that, again, came out of that body of research to show what works. You can see that there are several things that are mapped out or listed on the ribbon or the graphic on your screen, starting at the bottom. And we're not going to talk about all of these today. We're going to focus primarily on the one in the middle, target intervention, but just to run through this list very quickly with you. One of the principles is risk need, assess actuarial risk. So this principle guides our profession in using actuarial risk assessments to determine what is the person's risk to reoffend and what services, what areas of their life do we need to target. So that's the first step. We should always assess that using an actuarial risk assessment. The second kind of stage or step in the ribbon is to enhance intrinsic motivation. Again, a large body of research came out and that still continues to be published in our field, showing the importance of tapping into an individual's intrinsic motivators. The next one up is that we should target those areas that are uncovered from the risk assessment. We should target our approach and our intervention toward those areas that are identified from the risk assessment. And again, we'll dig into that one in a moment. Moving our way up, the next principle is to provide skill training. So again, kind of back to that rehabilitation approach. So provide skill training with directed practice. Again, guiding the individual how to practice the skills, how to develop skill proficiency is an important aspect of supervising justice-involved individuals. The next one, to increase their positive reinforcement. Again, quite a bit of the work that we do in corrections or in probation is to institute incentive and sanctions charts. So kind of the emphasis here on the incentives. And then the last one, to engage ongoing support in the communities, to develop those protective factors and those pro-social supports that are going to help the individual transition back into their day-to-day non-criminal life and behavior. The outer ring applies to the agency. So agencies are instructed to always measure their relevant practices. So if we're guided to provide evidence-based approaches and practices, the agency is tasked with measuring those to make sure that we're doing it well and we're doing it with a high degree of fidelity. And then the other side on the left is to provide feedback back to the field so we can continuously improve. Again, sorry about that. I'm going to watch the chat if anyone has any questions, or if you want to just hang on to your questions as I go through this. Again, I'm going to go through the information at kind of a quick pace, but again, if I'm going too fast or too quickly, let me know if you have questions. Again, I'll try to keep my eye on the chat. So again, as we break down, or as I break down some of these principles for you, I'm going to do that in the context of a case. So what does this look like when we apply risk need responsivity to an individual, to an actual person on supervision? So we have just an example here of a client that might be on my caseload. I have a new individual on my caseload, so I'm starting at the beginning. When we start in terms of supervision, we should always have goals in mind, much like I'm sure most of you do when you interact with a client, whatever capacity that might be. We start with our goal. So what am I trying to accomplish with Rachel? So again, being on the correction side of things, the goal for the most part, and there's a variety of goals that go along with this, but the goal for the most part is to reduce her risk to reoffend. So improve her successful completion rate, reduce her risk to use substances or engage in any other problematic or delinquent behavior. So that becomes my starting point for the goal. As I move forward, this is where I need to rely on the research to help me do that. So if my goal is to reduce her risk to reoffend, I have to understand some things from an evidence-based perspective about this particular client. So really moving away from supervising based on our gut or our intuition. So we've made great strides in our profession to move away, especially in terms of a probation officer or line staff, move away from thinking about what their past experience might dictate. So in other words, thinking about, well, I think I have a good idea what Rachel needs, or I've had other clients like Rachel and this is what worked for them, but really moving away from professional discretion and relying on the research. So again, to hit my goal, in order to reduce her risk to reoffend, I have to understand a couple of things, again, from that evidence perspective. I have to understand what specifically is putting her at risk. And it might sound simple on face value, but I have to understand what's putting her at risk. If I'm going to lower her risk, I have to have a good understanding of that. What does that look like in her life? How does that contribute to her problematic behavior or criminal behavior? And then the second part of that, once I understand and I identify the what, then I have to work to understand the why. So what does this particular area look like on an individual basis in her life? Again, to do that, I have to rely back on the R&R principles, or the principles of effective interventions, but specifically 3 key principles that we're going to talk about this morning: principle of risk, principle of need, and the principle of responsivity. So again, just a quick kind of overview here. This has become, since the 1970s, 1980s, really, when a lot of the R&R research was coming out, it has become the premier model. So again, solidly, established in the 1990s, and now it's currently used all around the world. It's the only theoretical model that has been used to interpret a justice-involved individual's exposure to criminal behavior, or from the treatment literature. Interventions, the research shows that interventions that adhere to all 3 of these principles, risk, need, responsivity, are associated with significant reductions in recidivism, whereas supervision, treatments, programs that fail to follow these principles and really follow all 3 of them yield minimal reductions in recidivism, and in some cases, as I'll show you on another slide, actually increase a person's risk to reoffend. And so again, this has become the core of what we do on the corrections side of things, to always adhere to the principles of risk, need, and responsivity. So what do these principles mean? In a nutshell, it's the who, the what, and the how. The risk principle tells us who we want to target. The need principle tells us what specifically we want to target with that individual. Again, moving away from our intuition or using our gut. And the last one is the responsivity principle. This tells us how. How are we going to target those particular needs for this high-risk individual? And so breaking it down individually, the risk principle identifies the risk level of an individual. In other words, what is this person's risk to reoffend? Are they at a low risk to reoffend, medium, or high risk? So again, using that actuarial-based risk assessment to identify what is the justice-involved individual's risk to reoffend. Now, the principal part of it is what's listed on your screen there. The risk principle states that our level of service should match the level of risk of the individual. In other words, the higher a person's risk level, the more services, programming, treatment, contacts, homework we want to provide to that individual. The lower the risk, the fewer contacts and interactions we want to have with that individual. The research shows that when we target the right individual, again, it makes sense from a resource standpoint. If a person is at a high risk to reoffend, or they pose a high risk to the community, it makes sense that we want to provide more services to address that compared to a person that's low risk, that doesn't pose a great threat to the community or themselves. But there's more to that rather than just being wise with our resources. The risk principle, the research around this shows that when we overprogram, overtreat, oversupervise a lower risk individual, you can see the graph on the left, we actually increase their risk. We actually make them worse. So as you can see there, when you overprogram, overtreat, overservice a low risk individual, what you see there is that we increase their risk to reoffend by roughly 4%. However, with a high risk individual, we can decrease their risk to reoffend. So again, we can reduce the recidivism rate by 19%. This was just in one particular study. Other studies show in the 30% when you target risk, need, and responsivity. But this is just looking specifically at the individual, not necessarily the need principle or the services. So the takeaway from this is to know who exactly is high risk and who is low risk. And again, this goes back to the risk assessment to help us properly classify the individual. Here's another study looking at the difference between high risk and low risk individuals and using the providing services or treatment. If we start with the two bars on the right side of your screen, so we have high risk in the dark blue, low risk in the light blue. So looking at non-treatment. So when we do not provide any services, treatment to a high risk individual, we see the recidivism rate roughly around 51%. When we don't provide services to a lower risk individual or low risk individual, it's around 14%. And now we're going to shift to the one on the left. What happens when we provide services and treatment to high risk versus low risk? Well, the high risk does exactly what we want it to do, that there's a reduction in their recidivism rate. So a high risk individual that's involved in treatment and programming now has a reduction in recidivism rate rather of 31%. So we can see that reduced from 51%. Again, going in the right direction, is that what we want? But again, when you take a look at what happens to the low risk individual, we've actually increased that person's risk. So again, we typically have a hands-off approach, the lower the risk of the individual. And again, that's the risk principle. If we apply this to our case, so again, going back to Rachel, the first step in supervising a justice-involved individual is to look at that risk assessment. So look at the actuarial based assessment to see what is the assessment identifies her risk level. Again, taking my discretion out of it. So I might see anything from very low all the way to very high, depending on the risk assessment I'm using. So this example here, this would be from something called the LSIR, Level of Service Inventory Revised. So using the LSIR with Rachel, she's now in the very high category. So the research shows from this instrument that individuals in this category, 44% of them are rearrested in the first year. So again, that tells me as a supervising officer, I need to map out a very specific, very strategic case plan for Rachel. Well, how do I do that? Well, what do I focus on? How do I know where to begin or what to do next? And that's where I go back to the research to look at the need principle. So the need principle, again, tells me what to target. Risk principle tells me who, so she's in the higher risk category, so I'm definitely going to focus most of my time and attention on her compared to a lower risk individual. The need principle tells me what specifically do I want to focus on in her life. And so this is where we get into what are called the criminogenic needs. The research shows that when we target these criminogenic needs or crime-producing needs, we'll get a greater impact on outcomes. So it will result in a reduction in future criminal behavior. Just some terminology to go over. Risk factor can be anything. So just distinguishing criminogenic need from risk factor. Risk factor is any characteristic, related to recidivism. There can be static things that do not change. So what might be a risk factor might be her age at first offense, the number of adjudications, other things, kind of just looking at her criminal history alone. All of those things contribute to having an elevated risk to reoffend. So those are certainly things the risk assessment takes into consideration. However, it's not dynamic. Dynamic risk factors are things that can change, such as her drug use, her antisocial peers, or any educational needs. So crime producing, as I mentioned a minute ago, just means crime, or criminogenic rather means crime producing. So I want to focus on areas of her life that are likely to produce criminal behavior. Again, and I'm looking specifically at the dynamic needs. So again, criminogenic needs are just risk factors which predict recidivism, and they're changeable, they're dynamic. The risk criminogenic needs have been broken down into two essential categories. We have at the top what are called the big four. One of them is static. So you'll notice that history of antisocial behavior, it's a number one predictor of future criminal behavior. So it's largely considered in the risk assessment. However, it's static. So we don't focus on that one, but it is included in the big four. The other top three predictors are attitudes. So the way you think, antisocial attitudes, antisocial peers, and a domain that's called antisocial personality, but this is not what you think of in terms of antisocial personality disorder. This is just the domain label that's used to describe temperament, lacking skills or other skill deficits like problem-solving skills, coping skills, emotional regulation skills. So that describes her inability to maybe handle challenges associated with life or the stressors of life. Again, those are the top 4 predictors of criminal behavior, future criminal behavior. So when we start case planning, of course, we're going to use the history to really understand and unpack her criminogenic needs. But again, because it's static, we can't reduce it. So we're going to focus on antisocial attitudes, antisocial peers, and those skill deficits that fall into antisocial personality. There are some lower tier criminogenic needs we also want to take into consideration, and that will also be flagged from the risk assessment. Things like substance abuse, lack of education or employment, or lack of satisfaction with education or employment, having a lower family affection, poor supervision, poor communication, so issues with the family, and then also areas or risk factors tied to lack of pro-social leisure activities or lack of recreational activities. So these are the criminogenic needs we focus on in case planning as I start to map out a plan to lower her risk. There are also some non-criminogenic needs that largely we don't focus on. However, they can be stabilization factors. So if these non-criminogenic needs are creating barriers, officers or staff need to pay attention to them, need to attend to those, hopefully stabilize the individual. So things like medical needs, mental health, physical, if there's a history of trauma or victimization, other mental health needs like anxiety, things that, again, interfere with the individual's ability to gain from treatment. We need to make sure we stabilize and respond to those and then move back to the criminogenic needs. So again, as you see on your slide, the primary target of any program and intervention in criminal justice is to address those criminogenic needs. So the better we do at reducing someone's antisocial thinking, impact who they're hanging around with and try to replace those with pro-social supports, address those skill deficits, the better we do, the more successful we are in reducing future criminal behavior. Again, so going back to Rachel's risk assessment, again, she was scored in the very high category, but that instrument will also tell me specifically what areas, what domains or criminogenic needs were scored as high, low, or essentially problematic for her. So you can see, because she's high risk, criminogenic needs are a subset of her risk level. In other words, the more criminogenic needs she has, the higher those criminogenic needs are scored, the higher her risk level. So those two things go hand in hand. If I want to reduce her risk to reoffend, I have to reduce these criminogenic needs. So again, this gives the officer a starting point to take a look at what areas are problematic for her. So again, you can see that for an officer supervising higher risk or very high risk individuals, there are a lot of targets that they need to address throughout supervision. So again, this gives us a starting point. The officer then has a variety of skills in their toolbox or under their belt that they use to be able to prioritize these, to figure out which one is the most problematic for Rachel, which one might be driving other criminogenic needs, or which one contributes to her most imminent risk. And that's how an officer prioritizes and starts to create a case plan, only focusing on one, maybe two criminogenic needs at a time. Now we get into the responsivity. So now that we have our targets lined up, now we get into, well, how am I going to address those areas? So lastly, the responsivity tells us specifically what I need to pay attention to in terms of Rachel so that she can get the most out of treatment as possible. So again, how am I going to reduce her antisocial cognitions? How will I address her skill deficits? So I have to understand a little bit about Rachel specifically, her learning style, and then also the bigger picture of what works best in this population. So responsivity, again, is just how will this person respond best to our treatment and services? Are there things that might be getting in the way or might create barriers from her benefiting from our services? And then how do I reduce those? There are two areas that fall under the responsivity principle. We have general responsivity and specific responsivity. General, this describes the body of research that looks at, well, what works best for this population in general. Justice involved individuals have different learning styles, different treatment approaches work better in this population than the non-offending population. And so the research shows that we should employ strategies that incorporate behavioral approaches, social learning, cognitive behavioral therapy, and skill building exercises. And so that's where I would say officers, for the most part, they're doing a better job at including interventions that have a CBT kind of approach to those interventions. They're incorporating skill building, working on role plays, focusing on social learning. So trying to incorporate more of those strategies in their one-on-one interactions with clients. And then we also see this consistently, I would say for the most part, in treatment and programming services that are provided through the courts. The second part of responsivity is specific, and this looks at the specific individual. Again, general is for this population in general, but specific is, well, what's going to work best for Rachel? So I have to understand a little bit about her learning style so that I can adapt my style, my mode of service according to her characteristics. So with every client on supervision, officers are instructed to take into consideration, well, what are her strengths? How can we have a strength-based approach? In other words, what protective factors does she have? What's working for her? How can we leverage those strengths to offset some of her risks? We also want to take into consideration her motivation. So I'm sure quite a few of you are familiar with the stages of change model. Officers as well take that into consideration. What stage of change is she in terms of her friends or in terms of her substance use? And we want to match our approach to that stage of change. Is she motivated and ready, or is she lacking awareness, unmotivated, maybe in pre-contemplation or contemplation? Other things that officers should take into consideration are her preferences, personality, age, gender, ethnicity, cultural identification. So all of those things, again, trying to match, well, what approach will work best for her? Again, what's her learning style, and modifying our approach to do that. So again, coming back to the same quote that I started with, if I want to lower her risk to reoffend, I have to understand what is putting her at risk. So I have to understand her criminogenic needs. And then I work to understand specifically why. Why do those areas impact her life? And then match my approach using the responsivity principle to lower those risks. So that concludes the overview of the risk need responsivity principle. I'm not sure how I'm doing on time, but I'll open it up for questions if that's appropriate now. If not, I'll let the facilitator kind of take over there if there's a different style, if you want me to hold questions.
First of all, thank you so much, Melanie, for this wonderful presentation. We do have a few minutes for questions, so I will open up the floor if there are any questions or comments from our learning community here.
One, so a lot of our clients aren't ready to go into recovery from substance use disorder. They have learned that they're dual diagnosis patients and they're using up meds, heroin, methamphetamine, or whatever, serves a need for them. It either decreases the voices if they're schizophrenic, it relieves it for heroin and some of these other drugs, it gets rid of their anxiety, and they're not ready to give that up. So how do you motivate a client to move away from those maladaptive behaviors, which are working for them? Understand it's working for them, but are criminogenic.
That's a great question. That's a very difficult question to answer too. I'll give you the simple answer, but obviously we deal with human beings and human behavior is more complex than this. Certainly there's a variety of things going on with an individual. We're not any different from that. We might do things that we know are probably not the best decision for us or not the best behaviors, but as you mentioned, we get something out of it. So we're getting some sort of gain out of it. With clients that are using substances, whether they're in the criminal justice system or not in the criminal justice system, oftentimes if they're in one of those not ready stages, they they either don't recognize the benefits or the positives, the pros associated with that pro-social behavior. Maybe they overinflate the cost of changing that behavior. So in other words, I might start thinking, wow, that's how I cope, and that's going to be terrible. I'm not going to be able to manage. And the last thing that happened. So they might overinflate the cost associated with changing, or they're just lacking the skills to move forward. So if they don't feel like I don't have an alternative, and for a lot of these clients, or the clients that you mentioned, these are legitimate concerns that they have. I don't have a solution for this need that this particular behavior is meeting. And so without that, they remain stuck. So again, it's a variety of different approaches. The first, I would say, we always want to increase their awareness of the pros associated with the pro-social behavior, increase their awareness of the cons associated with the negative behavior, but then also work to help them resolve whatever those barriers are, whether that's increasing their self-efficacy, providing tools, providing solutions, trying to counter whatever that problematic behavior is, trying to counter with a less maladaptive behavior that might give them the same outcome or meet that need. Again, easier said than done, but based on the research of the stages of change, those are the recommendations to target someone in pre-contemplation and contemplation.
And if I can add to what Melanie is saying on that, just from my experience, those are some those kinds of individuals at that stage. Is what Melanie was talking about, is we probably need to stabilize them first before we can even think about wanting to work on increasing that awareness, trying to help them to change and move towards wanting some of those things in life to change. So, I mean, I think those are some areas that you have to work on first to stabilize, whether they need to, detox, or whether they need to be in medicated assisted therapy or something in order for them to be able to function in wanting to even change or consider it.
Thank you so much. Lindsay?
Yeah, so I was just going to say, from my experiences, right, because I'm a peer, for me, it was a lot about, I heard, especially all growing up, right, I had a lot of issues with like self-mutilating, cutting, and like that was my coping mechanism, and I didn't know anything else. And it wasn't until I learned those skills, because you can't just take away somebody's coping mechanism, whether that's drugs or something else, without replacing it, because then they're left with nothing, and that just never works. So it never worked for me. So really, like, being taught the skills I needed to replace that with. And then with substances, it was also a matter of replacing that. Like, I used methamphetamines, so I came off of it by using Adderall, right? So I stepped almost like a step down from it. So I replaced that, the methamphetamines, with something else that helped. So that's, for me, I think that was the most important thing, was really having something to replace that with.
Great point. And again, this idea of essentially countering, replacing that behavior. So again, there are two approaches that are mentioned, in addition to some of the other ones that approaches that are mentioned from the developers of the stages of change model, Dr. Prochaska and DiClemente, talk about not only countering, so replacing, either countering your thoughts. When I start thinking, I need to do this, or maybe whatever those maladaptive thoughts are that lead to the behavior. So countering, replacing those thoughts, but then also having behaviors that, as Lindsay just mentioned, gosh, I don't know, I'm stuttering today. As Lindsay mentioned, countering those behaviors. So what will I do instead? You can't just take a behavior away. The other thing they mentioned is environmental control. So changing your environment, which again, doesn't always work, but if we do those two things together, change the high risk environment, that's where, at least in corrections, we talk about people, places, and things. When you recognize what increases your risk or what's likely to be a trigger for you, we talk about relapse prevention plans. Okay, how do we avoid those things? And then how do we counter when we can't avoid them?
Thank you so much. And I do see, Janelle, your hand is raised, but we do have to move on to the next part of our session. So if you could please share your question or comment in the chat, and we can continue our discussion there. All right. Thank you so much. And thank you again, Melanie, for this wonderful presentation. We will now move on to announcements. Karen, if you could please share the announcements. The Center for Substance Use Training and Telementoring provides high-quality education and best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.yathiska.edu. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive expert feedback from our hub members. There is no need to present a formal presentation as you'll see today. We will provide a case form to fill out to assist with your case presentation. Do email us at cstat@yathiska.edu. Next slide. Join us for our second Texas session of the year on Wednesday, November 15th. To register, visit texas.org/sessions. Next slide. Texas Substance Use Symposium will be taking place on February 29th and March 1st, 2024 in Austin, Texas. Texas is now officially open to sponsors and exhibitors. If you're interested in learning more on how to become a sponsor or exhibitor, please visit texas.org/sponsor Texas. Next slide. Please join us for our next ECHO session on December 14th with Aaron Ferguson. And with that, we will move on to the case. Karen, if you could please share the case, and John, you can take it away when you're ready.
All right, good morning, everybody. My name is John De La Garza. I work for the fire department. And the case that I'm going to be presenting today is over a time period. It's not necessarily in regards to a certain time period, but over almost a 2-week period. And so the questions that I would like to be addressed by Public Safety Solutions is, does the court probation department allow parolees to be on methadone, buprenorphine, naltrexone, medication-assisted treatments for OUD? And the other one is why is peer support an often underutilized resource in this population? And so to begin with, the setting and context of this encounter was San Antonio Fire Department MAT team engaged with a parolee who had an OUD at his home. We were able to stabilize him with buprenorphine and get him referred over to a clinic. However, during that day that after we treated him, he had an appointment with his probationary officer. And during that encounter or that visit with his probation officer, that prohibited him from getting MAT treatment services. And so in doing so, I reached out to peer support organizations, county departments and rehab facilities who collaborated in navigating this client into services that complied with his probationary stipulations. And so the strategies that I employed to manage this encounter, initially the MAT team educated the client on buprenorphine. Peer support was already working with this individual, and they frequently engaged with the client and promoted treatment and harm reduction benefits. However, when MAT services were denied, we reached out to all these organizations to see if we can come up with a care plan to getting him into some kind of treatment. And so our standard operating procedures with the fire department's MAT team is we're a low barrier treatment team of 2 paramedics that treat overdose survivors and refer them to clinics and organizations that provide substance use disorder treatment. We typically get a HIPAA authorization that is required for navigation and enter them into a suitable system of care. Buprenorphine inductions and daily dosings are performed until the client is accepted into care. So this individual that we treated was using heroin and had recently was released from the Bexar County jail system. And I believe that he was also attempting to treat himself with Suboxone off the streets. So some of the relevant context about this person is he was a 33-year-old male, Hispanic, living at home with his mother and one sibling. He was on community control through a Bexar County Probation Department. He had a prison ID, no job, no insurance, no medical care, wasn't affiliated with the PCP. And one of the other things is that he had no phone. And so the barriers that we faced in the encounter, the MAT care plan for this parolee, it was a violation of his parole. His abstinence-based treatment may lead to relapse and subsequent legal challenges. Medication assisted treatment, even with naltrexone, may prevent relapse and decrease cravings. And so what went well with this encounter was obviously the collaboration of all these organizations that came together with the rehab center, fire department, and justice system. We were all able to navigate this client and refer him into an inpatient rehab center and sober living. And so if there was anything that I would have done differently with this case is I probably would have initially contacted the probationary officer to kind of explore or maybe see if he would be willing to entertain treatment. The success for this case, it looks pretty good. He is currently in a 90-day residential rehab program and is connected with peer support in and outside of his rehab facility, meaning that currently he does have that support in the rehab facility, but because he was already connected with peer support outside, when he is released from that rehab facility or gets discharged, he will probably continue with that type of peer support. One of the benefits of also completing that rehab treatment or that inpatient treatment is that we hope that medication treatment will also be available for that individual and maybe might be considered by his probationary officer. So given the client's boundaries, I feel that the referrals made entered the client into multiple levels in the opiate recovery harm reduction continuum, providing him continuous options to his care plan and room for success. And so we're open for questions now.
Thank you so much, John, for your presentation. And yes, I'll open up the floor for any questions or comments on the case.
So, John, you did a pretty good job at trying to navigating him, wiggling and waggling. So we couldn't provide him with MAT, medication-assisted treatment. So instead, we pivoted and we changed his environment, right? So we took him out of the environment he was in, put him in a very controlled setting where he could work on his abstinence-based program through resources and inpatient programming. Maybe not the best way to manage it, but certainly an alternative way. And like you said in the case, I think it's important that when we reach these encounters to actually reach out to our probation or parole officers. Those two very different things, as Cynthia taught me earlier, to try and mitigate the barriers that may make this person successful. He may do really well with this change in environment and inpatient program, but The data probably shows otherwise, right? And as we know, on these high risk folks, but this is an example to folks about maybe when you come up with these challenges, think out of the box, use peer support, maybe transfer to a change of environment, a change in treatment plan if you can't do one or the other in your treatment process. So I think that's what this displays.
Thank you.
Cynthia, this is your turn.
Yeah, yes, this is most definitely a situation where we probably need to get, like Dr. Miramontes says, step out of the box, and I know we're really swamped in our field and our work, but maybe go in and just sit down with all these individuals and say, you know what, these are some things that work. Let's try it. I mean, we've got nothing but time with this individual, and hopefully we can save a life.
Hello, can you hear me?
Yes, Melissa, go ahead.
Yes, thank you. I'm Melissa Lucio with Bexar County. I just wanted to take a quick moment to comment on the collaboration. Alfred de la Garza called, made the connections. Everyone was utilizing the community that could help. The Corazon Ministries was able to get, their outreach specialists to go out and look for the client. And we were able to screen him at an encampment. And so this is what I'm talking about with respect to, it takes a village to work with folks, and that the engagement has to be wherever the client is at. So we've got to meet them where they're at. And so John de la Garza did an excellent job in getting everybody together, making sure that the provider Lifetime Recovery was on board, which they did an excellent job, making sure that the client had the detox needs that he needed, which he did. He needed that before he went over to Lifetime Recovery. And the other thing is the great communication, not only with the client's parole officer, Mr. Brunley, but also with the client's mother. So basically, this whole interaction and engagement was done by several people that John was able to get together to help this client. So I just want to congratulate John de la Garza for doing such an exceptional job. That's what we do. We just need to reach out to each other. Not everybody can be that one person that saves the one person. It takes a village. Thank you.
Melissa, I'm so glad you came in to talk to us about that. You might be able to answer this one question.
Yes.
Do you have any knowledge? Because I know you worked in the parole department.
Yes, ma'am.
As a counselor. Do you have any knowledge if there is an actual rule of conditions for parole that they cannot be an MAT?
Yes, ma'am. In fact, when John contacted me, I was able to contact the parole officer, and he was working there at parole 22 years. Unfortunately, it was condoned. It was looked and frowned upon, MAT. And so for the longest time, Michael and Zito, we tried to change the perception of that. We always ran into barriers, but yes, ma'am, they do not condone that. They frown upon MAT. And so in talking to parole officer Brindley, he was able to obviously accept the fact that the client needed residential treatment. So that's how we were able to connect the client to Lifetime Recovery. But yeah, that's something that definitely we have to do as a community to see if we can immerse our board commissioners into the fact that methadone MAT does work. And so that's a great question, Cindy. I would hope that, I know that you and I have been working for a long time in this industry, that we could make some change in that arena.
Thank you so much, Ms.
Of course.
So this is Dr. Clancy. So I am in Harris County, and obviously Harris County is surrounded by a lot of more conservative and somewhat rural counties. And, certainly we have faced the same issue. It's actually a violation of the American Disabilities Act to not allow someone to be on a medication for their medical treatment. But I know it's done. I'll tell you, specifically about an situation that came up in, one of the neighboring counties. The addictionologist wrote a letter to the judge and basically outlined why the patient needed to be on the medication, and they were allowed to stay on it. But we have to realize judges, I think in the state of Texas, are required to have a GED in some areas, and that's maybe it. They're not medical professionals by any means. And yes, exactly what the woman said before. It's not condoned, but when you are thinking that if you do not participate correctly, that you're going to lose your kids, or you're going to go back to jail, or whatever the situation is, people are, coerced technically into getting off medication, and we know what those outcomes are if they need that medication and they're not getting it. So I'm the secretary of the Texas Society of Addiction Medicine. That is an advocacy role that we're going to jump into more this year. I'm also a J-Coin scholar. So basically, I've had some specialized training in reaching patients in the prison population. The Academic Consortium of Criminal Justice Health has a lot of resources on how to advocate for patients that are in the criminal justice system or recently out. And I just wanted to share the Use and Recovery Initiative was part of several organizations that have been collaborating, like many organizations collaborating with the sheriff's department and their drug court and the health department and in the community in Galveston County. And yesterday we installed a Narcan vending machine at the jail pickup so that people that are leaving jail can have access to it, or their family members that are coming to visit or bonding them out, or their friends, they have access to it, right? Because people who are at risk or risk adjacent, sorry, it's lunchtime, are the ones that are administering the Narcan, right? So we want to make it available. But this took a year of collaboration to make this project happen. And ultimately the key piece was that a very high ranking officer for the Galveston County Sheriff's Office also happens to be a paramedic, right? So when you've been administering Narcan for 30 years, you have a opinion about it, right? So they made the decision really from within, but it took community prompting to start having those conversations. Dr. Miramontes, you can let me know. I don't know if we're the first, if this is the first jail in Texas to do that, but certainly it's among the first. But ultimately, we all want better. We all want these people to stay alive and have healthier lives, but we have to have the coordination, and all of the community organizations need to be collaborating instead of just working on their each individual pieces. That's how they get the biggest voice. So in Harris County, it's the Use and Recovery Initiative. There's several other ROSCs across the state, and that's their role, is to connect people in treatment with resources in the community. It's really a joy to hear this question being asked and see such a variety of input. So I'm super excited to be here. And I'm going to put my info in the chat in case anyone needs to reach out to me for Harris County.
Thank you so much, Dr. Clancy. And in the interest of time, I will request Dr. Miramontes to summarize the case for us.
Yep, let's wrap it up. So we heard in our presentation, we heard what works, punishment versus rehab. It's all about the rehab by using our R&R principles, which was identify the risk, figure out what the client needs, And then using your responsivity principles, it's lunchtime. How do you target those needs for effective management? I learned a lot personally about the probation, the criminology world that I'm not exposed to. And I thought that was a great way of bringing this forward to our system. And then our case kind of flipped into that. So we have a person who was not housed, very unstable in their environment, substance use disorder, and struggling with other issues, including psychiatric disease that wasn't addressed. And we heard a story about how one thing didn't work. So we went a different direction using the village and to try and make things better for this client. And then we heard from our presenters and those that collaborated that there are initiatives all through Texas to try and make this system a little better. I can tell you, for example, where I'm at, the jail's not doing that, right? So that's a problem. And we need to make sure that we are able to, in order to help somebody, they can't be dead. They have to be alive so that we can help them in the future. And I think that we also heard from our presentation, another quote that I got from the New York Times says that punishment does not develop new skills that will change my life for the better. So I think we've heard a lot of ways in which we can move clients and patients in a different direction through nudges, through education, through programming, and perhaps medication to make their lives better so that they stay out of jail and become productive members of our community. So this was a really good circular day today here. We started out with some good didactics, a case that kind of accentuated some of the principles of that didactic, and they're wrapping it up with some great input afterwards.
Thank you so much, Dr. Miramontes, and thank you all for joining today's ECHO session. As a reminder, to earn continuing education credits, please complete the post-session survey using the link in the chat. If you would like to present a case, please email the BWell Texas team. We look forward to seeing you at our next session on Thursday, December 14th. Have a wonderful rest of your day. Thank you. And go get that lunch.